But changes that people will swear by, change in their body composition. There have been studies that show that it will decrease bone demineralization, but there's yet to be a study that I could find in my research that has shown that it will reduce risk of fracture. So that's kind of like the standard of, okay, well, if we're going to do something to prevent or to promote bone health, let's really look at something that will prevent a pathologic fracture. And testosterone has not been shown to do that yet. There have been some studies that have shown that it will reduce your LDL cholesterol. Clearly, it will increase libido and decrease your erectile dysfunction. There's also evidence to suggest that there's synergy between testosterone supplementation and PDE5 inhibitors, Viagra, Cialis, Levitra are the three on the market, so that if you have an ED and hypogonadism, testosterone alone or PDE5 inhibitors alone are okay, but you put the two together and the guys report even better function with erections. Side effects, they're rare, but you can get CHF or fluid retention. For some reason, sleep apnea, and I'm not sure the pathophysiology of that, gynecomastia. One of the big areas is prostate cancer. So we talked about that guy, that older guy, the 85-year-old, and I think that there's something dramatically wrong. And maybe I even check a PSA, maybe it comes back at 1,000, and the guy has metastatic prostate cancer. The way that I describe testosterone with respect to prostate cancer is that prostate cancer is like a fire, testosterone is like gasoline, and you put the gasoline on the fire and it's going to flare up. If I can do something such as a Trelstar, Zoladex, Lupron that will suppress the gasoline, the fire will still burn, but it won't rage. But there has been no data to suggest that testosterone causes prostate cancer. So that's a big fear that a lot of guys have. You can give testosterone and not have to worry about causing prostate cancer. It is contraindicated, 100% contraindicated in patients who do have prostate cancer, though. And I had one patient recently who had to take off of their testosterone for that. And lastly is erythrocytosis or polycythemia. You can get an elevated hematocrit, so when I'm checking levels, I check a CBC as well. But I think that's it on testosterone supplementation that I have. Any questions about that? Jeff?
Well, this might be difficult, but you mentioned my favorite disease, apnea. And of course, all those patients that I see with apnea are not usually, not all, but you know, a very high percentage are overweight. So I had oral surgery, so if I slur, then I apologize. But my question, and this might not be fair to either of you, but who do we screen for low testosterone? Because if I looked at all my apnea patients, some of them probably have this, but I have no idea what percentage.
Well, I can say that I don't know the answer to that, and that one of the issues that now I'm starting to struggle with, and I'll tell you how I deal with it, is a 48-year-old guy who comes to my office and says, hey, I just saw my internist. My internist, as part of my yearly workup, he did a digital exam, he checked my cholesterol, and he checked a testosterone level. I say, oh, tell me why he checked your testosterone level. He says, I don't know. I feel great, and I go through the checklist of things that you would find with low testosterone, and the patient has none of them. He has good sex drive, he has good erections, he's fit, he works out, he's healthy, and he says, so are you going to supplement my testosterone? And I say, no, I'm not going to do that. So obviously, I'm only treating patients who are symptomatic and who are who have a low testosterone level as well. It's a very expensive medicine. All the insurance company or the drug companies, I'll tell you what I deal with in the office because it's kind of, I don't know how what to do, but I deal with it. But so it's expensive, and the drug companies say, hey, don't worry, tell your patients they're going to take this coupon to the pharmacy, and for the next 6 months, their copay will be $10, and that's it. You basically get them hooked. It's like crack. You get them hooked on the drug, $10 a month, and then at month 6, when they go to pick up their prescription at the pharmacy, it's $147 for the month, or $212 for the month. And they call me up and they say, hey, you never told me about this. So I tell them that up front, and I say, hey, listen, whatever the drug companies give you, that's what they're giving you. It's kind of gimmicky. They want to get you on this product. And the other thing is that insurance companies now, we're finding more and more, and this is probably within the last year, they are calling our office and they are requesting, in order to continue to pay for the, and I don't know how the legality of this, but insurance companies are requesting, and maybe Robbie can answer this, insurance companies requesting the level, they want documentation of the patient's low testosterone level, and if it doesn't exist, they are not paying for it. Can they do that? Can an insurance company audit a patient's record and say, we want proof that this level is low, to put you on the spot?
Unfortunately, the insurance company can do whatever they want.
Yeah.
There's no law that requires that they provide coverage for it, so they can write the coverage any way they want.
I would just add along those lines, one of the practical problems that we find is at what level do you supplement? And if you talk to any of the endocrinologists in town, they will all tell you under 300, under a level of total testosterone under 300, they're low and you should supplement. However, when you look at the labs, the normal range for most of the labs in the area will give a lower range of normal at 215, 195, 175, and they're all somewhat different. So it doesn't quite match up. And then when you go to the insurance companies, you'll say, well, they're 250 and they have this symptom and that symptom. They say, yeah, but the lab you used said the lower range of normal was 175, so they're normal, so we're not going to pay for it. So you run into all those kind of practical issues too.
Every single lab that I send to, Quest, HealthNet, St. Luke's, they have a different range. Every single one has a different range from normal, every time. But it's the same, microgram, picogram per, deciliter or whatever unit. But so it's not like we're comparing apples and oranges. It's the same unit, but there's different range for every single lab. I see that all the time.
Frank, for somebody who's had their prostate removed, they've had prostate cancer, their PSA is low or radiation therapy, can they take testosterone then?
Absolutely. So if you've had treated prostate cancer, no evidence of disease, and that patient has low testosterone, you can absolutely and safely replenish their testosterone. And those patients are going to get followed routinely anyway for PSA. And for example, PSA, everyone says, oh, it's a bad test, can't use it. Well, I'll tell you, the only thing in the body that makes PSA is the prostate. So when you do a Da Vinci prostatectomy on a patient, when they come back and get their first PSA at 6 weeks after you've had 4 or 5 half-lives of the PSA pass, their PSA needs to come back less than 0.1. Why? That's as sensitive as the assay gets. And let me tell you, when the PSA comes back at 0.1 or 0.2 or 0.3, you can't just say, oh, it's low. It's a big deal. A detectable PSA after Da Vinci surgery means that there is prostate tissue, and it doesn't necessarily have to be prostate cancer tissue. You can leave behind benign tissue at the time of surgery. It's very hard to see that when you're in there. Even with the Da Vinci robot with great visualization, you don't have pathologic vision when you're in there looking at the tumor. You can't say, oh, that's cancer or not cancer. And it's very hard to say, oh, well, I'll send a frozen section from that area. I do that quite a bit, and I'm finding less and less correlation between the frozens and my final pathology. So yes, to answer your question, you can get that safely. Harvey.
Just a couple points on that. First of all, there was a study that was recently done looking at elderly patients with low testosterone, and testosterone replacement really can have an effect on the quality of life. That's number one. Number two, it's important to screen for secondary causes. Obesity is the big cause of low testosterone. Simply by having patients lose weight and exercise can raise their testosterone level. You don't have to necessarily replace those patients right away. Drugs, a lot of drugs can cause low testosterone levels. Opiates are big offenders, like a lot of psychotropic drugs can do it. You have to screen those patients for that. And alcoholism. And just general poor health. Someone who's has other health issues can have low testosterone. Sometimes it's just a marker, maybe a marker of poor health necessarily, not causing, it may not be necessarily causative of any particular syndrome. And the third point I want to make is that there's a lot of variation in the testosterone level depending on when you draw the blood, do the blood test. So I think in general it's recommended you do it at 8 o'clock in the morning because there's a circadian variation in terms of the level of when testosterone is secreted. So there's a lot of controversy with that, as you brought up, Mike. And I think it's important to recognize. That's where the art of medicine comes into play. As we say, you have to look at the patient and see, make sure you exclude other causes of fatigue or other causes of the patient not feeling well necessarily before you jump on, oh, it's the testosterone.
Excellent points. And I absolutely forgot to mention that the variation during the day, you want to check a testosterone level early in the morning. Thank you, Harvey. And the other thing, too, is that I am seeing more and more patients, and other people in the room who do physical medicine or rehab or will tell you that so many more people are on fentanyl patch and low-dose OxyContins and oxycodones. And I'm telling you, those patients, almost all of them have low testosterone level. I see that, and I'm sure you see that all the time.
And that's why instead of stacking with another medicine like insulin inhibitor, say, hey, let's cut back on your oxygen.
Absolutely.
Right.
Absolutely. All right, any other questions or comments? We're going to try to wrap things up. We try to get out of here at 11:45. A lot of people, myself included, have to go pick up kids at Hebrew School. If not, thank you all for coming today.
Thank you.